Thank you very much, Kojo. Thank you for inviting me here. So as you just heard, I'm going to talk about the future of revision adult deformity spine surgery. Um, I do have some disclosures, mainly Medtronic, and it's relevant because some of the products I'll discuss are Medtronic. Um, so, just to give an overview, these are the things I want to talk about right now. My current workflow includes obviously planning, and we'll go with the different instruments that we use for planning. And then we'll talk about the intra-op execution of these. So the plan is for the next 20 minutes or so to go over these things to see how I currently use imaging as well as other modalities to plan my deformity, especially revision cases. And so this is a slide, I'm sure something similar many of you may have seen. This is borrowed from Dr. Lenke. Now, one of the first things I do in deformity patients, including revision cases, is to get these full-length spine films, including the lower extremity. These are extremely important now, for planning of our cases, because this allows us to see how the lower extremities are compensating for a lot of these patients. And when I was in residency, the most I think we saw was just a 36-inch scoliosis film, so we never really saw what was happening to the lower extremities. And now in practice, and also during some of our fellowships, the importance of seeing what's happening to the lower extremities has become evident. So here's a patient on the left side here, where you can see that their sagittal alignment is quite a bit forward, but they're also bending their hips and knees and ankles to try to stand up straight and still have a difficult time. And the goal is overall, obviously we talk about specific targets, but overall the goal is to match up all the center of gravity. So we want the center of the head to line up over the hips, knees, and ankles. And not only in the sagittal plane, obviously these images are important to look at the coronal plane. And some of the things that are important on the coronal plane, other than the obvious spine coronal malalignment, is to look at the pelvis, look at the femoral head, look at the leg length discrepancy to see if that's contributing to coronal malalignment. One of the things that we pay attention to now is also varus or valgus alignment of the knees that are trying to compensate sometimes for the coronal malalignment of these patients. It's difficult for the body to compensate in the coronal plane, even more so than the sagittal plane. So that's step one nowadays in my practice, is to, after the physical examination, as far as imaging is concerned, to get these full body images to really get a better understanding of what the problem is. Step two, again, talking about imaging, is to get an understanding of these patients' flexibility. And this patient's X-ray, I like to show this one because it really drives home the point. As you can see, this patient standing up, they have such a large amount of thoracolumbar kyphosis that you can barely fit this patient on the EUS imaging of the film. But as they lie down, you can see that the deformity corrects a lot. The film is not that great, but you can still get an idea that the patient is able to lie down quite flat. So, I guess 10, 15 years ago, this patient would have been someone many would have considered doing a pedicle subtraction osteotomy or a different type of 3-column osteotomy on. But now, using clinical exam, having a patient lie down prone, or even using supine images, just see how flexible the spine is, you can get an idea of how much correction you can get just from positioning. And so the first two steps are, you basically get an idea of how bad the deformity is, and second, how flexible it is. Third, now as we start to use more and more technologies, and I think you guys will probably see some robotic tools throughout this course as well, is for me, the third step in planning for some of these complex, especially revision deformities, is to plan the screws using the robot. The reason that I use this is that, for the most part, placing screws with the robot are quite reliable and accurate. It makes putting the screws the easy part of the case, so that you can actually focus on the more difficult parts, which are your osteotomies and corrections and intra-body work, decompression, all those things. And it also gives you the ability to plan ahead. That's a question I get asked often. Why do you not use navigation? What's the advantage of robotics? Well, it's really the planning. When you plan, you really get an intimate knowledge of the patient's anatomy, and you also can plan your screws and line them up the way you want them to, which you can't do with navigation ahead of time. So here's an example of a patient with prior Haddington rods who we were planning on surgery for. You can see here a huge fusion mass, as is the case for most of these patients, small pedicles, especially in the concavity, and then you obviously have the rod in right where the pedicle is supposed to go. And so just using robotic planning now gives you the ability to plan screws through the fusion mass without having to do laminectomies or laminotomies, or without having to do a lot of x-rays or other things like that. It just makes this process really easy. It also tells you if you can keep the rod in place or if you have to take the rod off to be able to place your screws. And so this is what ended up happening with this patient. We did cut the rod because some of the screw entry points ideally went through where the rod was in place. And again, this makes it very easy to place the screws, and you can focus on the more difficult tasks. Another case where the patient had a prior anterior fusion done somewhere else and had pseudoarthrosis. You can see the anterior instrumentation is dislodged and had pain above the construct and below the construct. And so, here's a 3D shot of this patient's image. There's some transition anatomy as well that can make sometimes putting screws in a bit more challenging. And the other key is all of these levels have two anterior screws, so there's really not a lot of real estate left. And so again, when performing regional surgery in these cases using planning software with a robot, it allows you to squeeze in these screws even where you may have found it difficult to do otherwise in such cases. And some of the screws, despite using these technologies, were planned as very short screws because there just wasn't enough space to put a screw in with those two screws anteriorly in each of these levels. Another thing you can do for these complex cases is, since this patient is fused with a bit of scoliosis, there's no way I'm going to plan to make this straight because then you have to break through anterior fixation and cages and all this anterior instrumentation. And so in order to avoid bending the rods in the sagittal as well as the coronal plane, you can align the screws in your planning so that you line them up properly. And so here, I kind of imagine that I'm going to have two straight rods, and then I move the insertion points of the screws to line them up in a straight line, so that when I place the actual rod, like this one, the rod goes in straight in the coronal plane, even though in the sagittal plane, you have the contour that you need to do. And overall, I didn't do anything to the scoliosis or the lumbar spine itself, but still looks straight because the rods went in straight and the patient has maintained their alignment in the coronal plane as well as good alignment in the sagittal plane. So that's a bit of a summary of why I use robotics. It makes placing the screws easy. I don't have to do big laminectomies, makes going through fusion masses easy. It's also really easy, good for S2 AI or ilia fixation, where you can limit the exposure in those cases and not have to expose a lot of the sacrum and ilium. Now, after the screws, so that's screw planning. The next step is really planning the realignment, and that's where I use patient-specific rods and tools for that purpose. And so this is what I used to do before I started using patient-specific instrumentation. Here's a patient who came in, had sagittal malalignment. You can see has had 6 or 7 prior surgeries to try to figure out what the problem is. He had sagittal malalignment, the SVA is high, you calculate the PI, you get the LL, you see that the pelvic tilt is a little bit on the higher side, other parameters, TPA, T1, SPI, and at this point, I have about 15 parameters. I'm trying to figure out, well, and all of these parameters may have different goals, trying to figure out what do I do with this. And so that's where the planning software really comes in, that it makes that easier for me. So, at that point, and the other thing is, even when you decide what targets you want to achieve, you don't have a way to confirm them intra-op, really all these other targets. And so, I would do this planning before surgery, and then intra-op, you're still kind of relying on your gestalt to bend the rod to the right shape, to get the right alignment. You're bending the rod a lot, so you're creating a lot of notches. Sometimes you have to bend this in situ with the dura exposed at that point, and so there's a risk of slipping and causing other injuries. So lots of issues going on, and not only do you have to bend it in one plane, you have to bend it in multiple spots. So you have to bend it at the main lordosis, but then sometimes for the iliac screws, you have to actually bend the rod into a bit of kyphosis, and then at the top as well, you have to ease in a gentle bit of kyphosis. So there's just a lot of contouring that happens to make these things go perfect. So, but you can still do it. This is pre-op versus post-op, really good alignment. But what I wanted to get to was that I don't have to guess anymore. And so, that's why I transitioned to using more of the patient-specific instrumentation or rods. Because I wanted to take the guesswork out of my cases. And so here's a patient who had undergone a previous lumbopelvic fixation, but decompensated really quickly, had connective tissue disorder. So essentially everything from C2 down to the pelvis was out of alignment at this point. And so then we planned, I won't go into the details, but we planned a C2 to pelvis reconstruction for this patient. And here's what it looks like. I get all my parameters on the side. The biggest thing for me is that I can visually see what this patient's spine is going to look like. So I don't have to look at these measurements to see whether the overall patient alignment is going to be good or not. You can get a visual representation of what the alignment is like. So that's what I like. And this is the outcome, which matches pretty perfectly what the rod was made. And the other nice thing about these instruments is that this is one single rod going all the way from C2 down to pelvis. Obviously, there are some accessory rods, but the main rod is one rod all the way down from C2 to pelvis, which is very difficult to contour in all these different planes to get the right alignment. And then as you compare your plan to post-op to later follow-up, you can see the lordosis matches up really nicely. And some of the other angles as well can match up really nicely to your planning. So that's the benefit of using all this technology step by step to get to where you want to get. I find it's also an excellent tool for confirmation of what you're getting intra-op. So here is a patient of mine who had surgery somewhere else, flat back, can't stand up straight. Again, we planned for multiple posterior column osteotomies and multiple T-lifts or intrabody. And then this is what we got. And the nice thing about this patient was that once I was done with all my posterior column osteotomies and screws and intrabodies, I just took the rod and laid it in there. And I already knew that I was close to the shape of the spine that I wanted to get with my correction. And so then at that point, the rod was a confirmation and also just holding that deformity correction. So you can see the pre-op to post-op. And the next step now is, we have the pre-op imaging, assessment of flexibility, robotics, patient-specific rods. Final step is trying to bring this all together. So this was a nice case, patient with a prior Harrington rod with multi-level degenerative disease and a bit of scoliosis distally, and you can see flattening of the lordosis as well. So I planned again with my screws, with the robot. But as you can see on the plan for the robot, you can see that the two rods look like they have different shapes. They're not the same shape, even though the lordosis is the same. And so here I realized that this patient, I have to leave a bit of lumbar scoliosis to match their remnant thoracic scoliosis. So I can't really fully derotate this patient. And so I had to use two rods of different shapes. And that was our plan. So when we planned for this, we planned for two different shaped rods to still get the same lordosis. And that's why we got intra-op. And then this is what brings us to the next step. We did all the stuff pre-op, we did the planning, we executed it. Well, this is how you confirm intra-op, obviously by putting the rod in, but then we get full-length films intra-op, and I actually measure the different parameters. I'll measure the L4 to S1, I'll measure L1 to S1 overall, looking at different parameters to see if we got the alignment that we were looking for, and even close up to confirm those things. And then don't forget the coronal alignment of these patients. And I use for these, again, we get intra-op full-length scoliosis films. And I use actually a T-bar type of device to place on there to see if this patient is well aligned or not. And here, the T-bar is not perfectly placed, but if you adjust that, you can see the patient was a little bit off towards one side. And so this showed me that I had to do some in situ contouring then to get this patient's coronal alignment perfect. And so that's what they look like post-op. They're standing up pretty well aligned in the coronal plane and the sagittal plane. We were able to maintain a bit of the gentle scoliosis to match up into the thoracic scoliosis, and then have the two different rods shapes, parameters shown here. We'll skip through this for a second. And you can see the patient is not compensating by bending their knees or hips anymore and well aligned in both planes. So that's the power of using all this different technology and planning. Other key benefits for me are that the PI-LL mismatch and some of the other concepts that we look at, they may work for the mean patient, but they don't work for every patient. And the key here in these, when you become more patient specific, you can really then see what each patient needs and how they're going to look like. as opposed to just kind of putting everyone into that PILL of plus minus 10 category. Some may not like to hear this, but I don't think surgeons, and it's been shown, surgeons are not as good as bending rods as we think we are. There's definitely less notching because you're bending the rods less, so there's less risk for rod fractures. And then some of these softwares also allow you to predict post-operative compensation in the thoracic spine. It does improve your predictability in terms of alignment, and then also, saves your hands because you're not having to bend things as much with your hands. So, and a couple of other examples here. Another patient with a Harrington rod. We planned everything pre-op. We planned the screws, planned the rods, and here, then simple execution. And I did not have to remove the Harrington rods or in between because I could just plan the screws all around it with the robots. Everything in between was just left in place, and good alignment overall. And this was someone who had extreme sagittal malalignment. Needed a 3-column osteotomy. You can see again this full-length images shows you how they're compensating in the sagittal plane, but also in the coronal plane with this wind-swept deformity of their knees. And so here, again, there was only one level that was not fused, and so we ended up using again the planning software, patient-specific rods, the robot, and did a L5 PSO. So I could just focus on the PSO and not worry about the screw placement and all these other things. And again, a pretty happy patient post-op with good alignment. This is a case with a different type of application of different technologies. Patients with severe kyphoscoliosis. I think this is close to 150 degrees of kyphosis at this point with the prior surgery, and you can see a cage sitting in there. And so in this patient, I think you tried to use navigation, didn't work, and the robot didn't work. And so as a backup for these patients, another method in terms of technology we use is we have 3D printed spines with us sterilely packed in the OR. So that if other technology doesn't work, I have a backup. I can see the landmark. I've planned my screws on this model as well to use as a backup for this. And I marked out where my VCR cuts are going to be and the cage. And in many of these patients, we also get a virtual representation of their 3D model. And the key thing I wanted to see for this patient was, well, how close is the aorta, if you go back, in this valley? How close does the aorta get to the spine? Because I'm going to be working all around this patient. And so, here using this 3D model, you can really get a good understanding of what's happening to the vasculature. You can see the aorta in front, and you can get different shades of these models. You can, now almost a translucent one. I can see the aorta is far away from where I'm going to be working, so I don't have to worry about it as much for my vertebral column resection. And a close-up also shows that actually the spinal cord is far away from the cage because I would have to drill this cage out to really do a vertebral column resection here. So these models, again, 3D models, software models, as well as printed models help a lot for these complex deformities. And this is what we ended up doing. And the case went quite smoothly, significant improvement in her kyphosis. And so the key is technology in spine is increasing at a really fast pace, and we have to understand when to use it, how to use it, and how to use it safely. You can have intraop CT scans, which we do use after screw placement to confirm. We have different types of robotic systems that are in the market now. I think at least 3 or 4 even. I use the ultrasonic scalpels a lot to do my osteotomies and decompression work. Different types of bone scalpels, patient-specific instrumentation, and now the next step that a lot of people are getting into is augmented reality or even virtual reality, which is shown here, and then 3D models. So all these are tools that we can use to tackle these complex spine deformities. So just coming back to my workflow as a summary, full body imaging of the patient to look at not just the spine, but the whole body of how the patient is compensating. Flexibility extras to see what we need to do. I use robotic planning for screws and to ensure that I have to do less bending in the coronal plane, custom rods for planning and then for deformity correction and confirmation, 3D printed models or 3D imaging when needed, and then intra-op confirmation with full-length scoliosis films, T-bars, measuring the X-rays, all those things to make things as reliable and safe as possible for these patients. And I will stop here and take any questions that you may have. Thank you again for inviting me.
Zeeshan, this is Martin Pham here. That was a great, really great talk. Good seeing you again. For the young surgeons in the room, how would you suggest that they go about all of these upcoming and current advances in technologies that are really changing how we view spine surgery? Is it enough for them because they're already fixed in certain residencies and fellowships that may or may not have exposure or access? Is it good enough for them to just know that this is out there so that when they go into their practice, they can either seek this out and request it? Or is there something that you feel they should be aware of in their training now to prepare them to essentially inherit these keys in half a decade's time?
Yeah, really, Martin, thank you for the question, and good to see you again as well. A great question. And I'll tell you, I don't think you have to wait to actually get your hands on these technologies to benefit from these technologies. The reason I say that is many of these things, as you saw, have a software component to it. So the robotic planning software has a software component to it. The patient-specific rod planning software has a software component. The 3D imaging has a software component. And before so in one of my fellowships, actually in Texas, I did a few fellowships. One of the fellowship in Texas, I had access to the robotic software. But when I started my practice initially, there was no navigation, no robot, nothing. But I would still use the software to plan out my screws and really to get familiar with the anatomy of each patient, sizing of the screws, getting the right cuts. And honestly, it shows you a lot of details. The other thing it shows you is also then, like I said, the shape of the rod or how the different rods are going to be shaped, how deep you want the screws to be seated, what your starting points may be changed to if you don't want to bend your rods in multiple planes. So, one of my suggestions would be you can still talk to these different I'm not, you don't have to pick one, but just whichever one of choice, talk to the reps, get the software, start planning. You can plan the screws, you can plan the correction. Those correction softwares, just the planning of those they are very powerful. And I would spend so much time. I think it's a good exercise to obviously measure things yourself, but it's a good exercise also to then have them do the measurement, compare, have them do the planning for that, see what that looks like, the different types of plans that you can ask them for. You can ask them, hey, I'm going to do multiple posterior column osteotomies, or you know what, I'm also going to do a 3-column. Show me the 2 plans, and I'm going to compare what you do. So I think those are some of the tools for planning you can already use, including the 3D software. And once you get into your practice, then you can figure out which ones you have access to and not, and what's going to be safe, and how you take a stepwise approach to gradually use those in your practice.
That's great. Thanks.
Thanks so much, and appreciate your presentation, and look forward to seeing you in person.
Thank you very much.
We're going to next.